Good evening, everyone. I'm Dr. Prasanna. Today we'll discuss about two main topics, that is HIV in pregnancy and Neisseria gonorrhea infection, chlamydia and all. PID. Okay. So first thing is HIV in pregnancy. So we all know people with HIV in pregnancy, they will come by taking antiretroviral therapy. Some patients will come without taking an ART. Okay, so to what patient what to do, and if she came in pregnancy without taking ART, then when to start ART, because ART also uh, some drugs are not that suitable in first trimester. Okay, I will tell that in details. So I think you can see my whiteboard. So basically, there is a drug known as dolutegravir. Dolutegravir. Okay, this drug is generally is one of the drug in ART. Generally, if a normal lady who is taking ART now became pregnant, then we should immediately stop this dolutegravir. Okay, because dolutegravir causes neural tube defects. If she is taking dolutegravir, then give high dose folic acid. High dose folic acid means at least 5 milligram folic acid you should give. Okay, this is the first point you should remember. Second thing, in case of pregnancy, ART generally when to start is generally we'll start ART at 24 weeks. Okay, generally we'll start as early as 24 weeks we'll start. Okay, so so when to start means according to RCOG guidelines, we'll see the viral load. Okay, if the viral load is 30,000, less than 30,000, if the viral load is less than 30,000, then immediately we'll start ART. Okay. If the viral load is 30,000 to 1 lakh, if the viral load is 30,000 to 1 lakh, then at the start of second trimester, that means only second trimester starts by 13th week, na 13 to 14 week, now second trimester starts. So at the start of second trimester only, we'll start giving the ART. Yeah, if the viral load is more than 1 lakh, if viral load is till the second trimester, better give the ART at first trimester. Only thing is, we'll avoid dolutegravir. Why? Why we'll avoid dolutegravir? Because it is causing neural tube defects. That's why we'll avoid dolutegravir. Okay, that's it. So, what are the compositions of ART? Generally, we have ART, that is TEAL. Okay, what is T? Tenofovir. E is imteracetabine. A is abacavir. L is lamivudine. Okay, once again I'll tell, right? TEAL. E is tenofovir. Tenofovir. E is emtricitabine. Emtricitabine. A is abacavir. Abacavir. L is lamivudine. Lamivudine. Okay. This is the composition of ART. Generally, we'll start this ART accordingly. Okay. How is that done is basically in case of second trimester, we'll generally start if the viral load is more than 1 lakh, then we'll start by first trimester itself. Okay. If there is very high viral load, so to cut down the viral load, then we will give the integrase inhibitor. And we will give integrase inhibitor. Like, what is the integrase inhibitor? Like raltegravir. Raltegravir can be given. Okay, that's it. Now I'll tell if a patient. Now I'll tell, for example, if a patient came and she came in labor, and the first thing is we'll take the samples and we'll send for some CBC and all. Na? At that time only send the sample for viral load. By viral load, because we'll see viral load is very high, then accordingly we'll give the medication, but basically we'll give a start dose of nevirapine. start dose of nevirapine, then you'll give IV zidovudine, then also will give a oral ART. Okay, if a patient came in labor, then we'll see the viral load, whatever it may be the viral load. Why I'm saying to see the viral load, to see the to decide mode of delivery. Okay, which I'll tell later. But basically, if a HIV patient came in labor, if a HIV patient came in labor, then you'll go uh, IV zidovudine, nevirapine, and also oral CART. Okay, and also oral CART. Mm. Then mode of delivery. I'll tell you the mode of delivery. Uh, so I told that we'll see the viral load, right? Uh, Viral load. We'll see the viral load and accordingly we'll decide the thing. So if the viral load, for example, if the viral load is less than 50, then we can plan that vaginal delivery. If the viral load is less than 50, we can plan vaginal delivery. If the viral load is 50 to 399, if the viral load is 50 to 399, then you will plan for LSCS. If the viral load is 50 to 399, we'll plan for LSCS. If it is more than 400, then we'll plan for also LSCS. Okay. If there is rupture of membranes, if there is rupture of membranes, then immediately you'll go for induction of labor. Okay, induction of labor and same. If the viral load is less than 50, we go for vaginal delivery. If same cesarean, if more than 400 is also, we go for cesarean. Okay, if there is free prom, if there is free prom, if there is free prom, then also we'll go for, we'll basically we'll give GPS prophylaxis as well. Okay, we'll give GPS prophylaxis and we'll go for delivery by 34 to 37 weeks. So what to do with infant? Infant comes under very low risk. Infant comes under very low risk if the mother viral load is less than 50, then 50, and she's taking ART almost 10 weeks, almost 10 weeks time. Okay, and even the viral load is less than 50. Even at 36 weeks of gestation, viral load is less than 50. Then the baby is very low risk. For this baby, you will give 2 weeks of zero wooding. You will give 2 weeks of zero wooding. Okay. If all these criteria are not met, okay, all these criteria are not met, then you'll give 4 weeks zero wooding. Okay, if the mother viral load is very high, mother viral load is very high, then the baby also comes as high risk. For this baby, you will give ZLN. What is ZLN? Zidovudine, Mivudine, Amivudine, and Ibuprofen. Okay, these are drugs you will give at least for 4 weeks. Okay, you will give at least for 4 weeks. And these three drugs is known as post-exposure prophylaxis for high-risk patients. You will give. If generally the HIV mother had a baby, obviously the mother generally won't breastfeed. So for the non-breastfeeding baby, what to follow up is generally we'll go for a blood test at 48 hours and you'll go for before discharge, then at 6 weeks of age, then at finally 22 to 24 months of age, you go for testing. Okay, if she's breastfeeding, then we won't go for before discharge. We'll go for 48 days, 48 hours. I mean, 48 hours. Matlab on the second day, 6 weeks, and also again at 20 to 24 months, we'll go for testing for HIV. Okay. Um, coming to coming to if there is HIV and hepatitis B, then you go for again the same things that ZLN you'll give. If there is hepatitis B also with HIV, then you'll go for ZLN treatment. Okay, and depends upon the viral load of HIV. And for the baby, as there is hepatitis B, you for the baby you'll give hepatitis B vaccine, and also you give hepatitis immunoglobulins. Pakka you should give. Okay, hepatitis B vaccine and also the hepatitis immunoglobulins. That's about HIV. Now coming to um, Neisseria. Okay. Now coming to PID. So pelvic inflammatory diseases generally of Neisseria, gonorrhea, and chlamydia as well. If there is chlamydial infection, generally you'll go for doxycycline tablet. Okay, doxycycline tablet in treatment you should also give to the husband. Husband also should take the drug doxycycline treatment. At least the male partner should get twice daily for 1 week. Okay, it's about chlamydia. So in chlamydia, generally we'll see in 72 hours you'll see the response. Okay, um, and 2 to 4 weeks you'll see, and after 2 to 4 weeks you again go for response. Okay, again 2 to 4 weeks you again go for testing, and sorry, you test all the contacts. Whereas for gonorrhea, you will repeat test after 2 to 4 weeks. Okay, so basically for Neisseria and gonorrhea, you will take the vaginal swab and you'll send a test for NAT. Okay, if and that is RNA testing. Okay, in case of Neisseria, you the treatment is ceftriaxone. In Neisseria, the treatment is ceftriaxone, whereas in chlamydia, you'll go for doxycycline. If she say, I don't want doxycycline, then you can go for azithromycin. Azithromycin 1 gram dose or else azithromycin 500 milligram you can give. Okay? Chlamydia, you should go for follow-up as well. By very important is even chlamydia cause neonatal ophthalmitis and Neisseria also cause neonatal ophthalmitis. How to differentiate both of them? So immediately within 1 day it will come. Then it is known as Neisseria. Then for the baby, you'll give ceftriaxone 25 to 50 milligram per kg body weight. Okay, it is a single dose. Whereas far as chlamydia also you'll get infant neonatal ophthalmia. But this is in after 5 to 12 days. Okay, for them, we can't give doxycycline enough for the unit. So you'll give an oral erythromycin, that is also 50 milligram per kg body weight. We'll give for 4 divided doses for 14 days. Okay, for chlamydia, you give for 14 days. Whereas for Neisseria, you give only a standard dose of azithromycin or else doxycycline single. So sorry, for Neisseria, you go for ceftriaxone or else azithromycin single dose. For chlamydia, you give doxycycline. So you'll give oral erythromycin 50 milligrams per kg body weight in divided doses for 14 days. Okay, and in case of Neisseria, there is a the discharge. There is discharge, and in the smears you can see the glue cells. And pH will be more than 4.5, and you can find the fishy odor. Okay, you can feel the fishy odor in the vaginal discharge. That is Hamza's criteria. Okay, for Neisseria, the recurrence rate of bacterial vaginosis is caused by Neisseria gonorrhea is 58%. How much? 58%. Okay. Coming to candidiasis, generally if there is candidiasis, you'll go for fluconazole 150 milligrams dose. But there is acute vulvovaginal candidiasis, and almost within 2 months there are 2 to 4 episodes. Then you'll go for fluconazole standard dose, and also you'll give thrice in a week. Um, thrice in a week for uh, yeah, thrice in a week you'll give for week. Then weekly you'll go for 15 milligrams tablet dose for 6 months you'll give. Okay. If there is recurrent vulvovaginal candidiasis, then if fluconazole is not acting, then you go for nystatin pessaries. If nystatin is also not acting, then you can go for boric acid pessaries. Okay. These are different treatment for candidiasis. Okay. Um, I hope this is understood. Mainly HIV is very important. Viral load is less than 50. Vaginal delivery 50 to 399. Cesarean section considered. And if it is more than 400, that is recommended to go for cesarean section. Okay. Thank you so much.